Welcome to part 1 of your pharmacology lecture. There are many objectives to this whole pharmacology series. This series encompasses a lot of PowerPoints and a lot of information. Many of these concepts you've previously learned when you took your nursing prerequisite courses before your acceptance into the RN program. This series of PowerPoints will go into the pharmacology and pharmacokinetics, how medications work in the body. These PowerPoints are not medication-based, they are concept-based. Knowledge in all areas is needed to be able to safely administer medications, so as you go through the program, you may need to refer back to these classes to help you understand the information. In addition to these, there are state and federal regulations, facility policies, and laws regarding certain types of medications. Our scope of practice also dictates how we can give medications. It is very heavily regulated, so making mistakes when giving medications is a big deal. The mistakes typically happen because we are not following the required steps or do not know the required information, and neither are valid excuses in the eyes of the law. Not following the steps or not knowing the information hurts people, approximately 400,000 people each year. When we look at medication names, there are two that are always listed, the generic name and the trade or brand name. There is also the chemical name, which is the exact chemical makeup of the drug, but nurses rarely see those names unless you go into research. The generic name for a medication is the official name for a medication, and it is typically long and hard to pronounce. The trade or brand name is the proprietary name. It's the name trademarked by the drug company. The trade or brand names give the drug company exclusive property to the medications. For example, acetaminophen is the generic name for the brand Tylenol. The drugs also have classifications they belong to. They can be classified by their chemical makeup, their pharmacological effect on the body, which is how the drug works in the body. This is called mechanism of action in most nursing books. Terms you may hear are beta blockers or ACE inhibitors or cephalosporins. We can also classify medications by the function or the therapeutic effect on the body or what the drug does for the body. They are grouped by similar therapeutic indications like anticoagulants, anti-anxiety, or antihypertensive. The classification term you hear most often really depends on what medication you are using. I use all of these terms all day long. And the last thing we need to do is that medications come in many forms. They can be given as injections, liquids, solids. They can be given through the skin. They can be instilled into body cavities, and many more. There are 6 different reasons for using medications, and we call these types of therapies. First, we have acute therapies. This means we are using these medications to treat a short-term, actively occurring issue in the body, like an infection or a heart attack. Then we have maintenance therapies. These therapies treat long-term chronic diseases like diabetes, hypertension, and heart disease. Next, we have palliative therapies. These therapies help make a patient more comfortable. It's not going to cure or slow down their disease, but it's going to improve their quality of life. This would be like giving a dying patient pain medications. Next, we have supportive therapies. These therapies help other therapies work or help keep the body alive while the other therapies kick in. This could be hydration or blood products. They're not going to fix the issue, but they will help while we find the real therapy fixes the issue. Next, we have prophylactic therapies that help prevent a disease. This would be vaccines or medications being used to prevent diabetes from occurring. And last, we have supplemental therapies. These are the things that can be done in addition to medication and typically involve vitamins, minerals, and herbs. Next, we're going to spend some time on pharmacokinetics. This is really important information, so I broke each concept out for you. The reason why it's so important for us is we need to know this information when we give medications. Nurses need to know how each medication is absorbed, distributed, metabolized, and excreted. Why? Because IV forms of medication will absorb faster than oral. People with liver or kidney disease may not metabolize or excrete medications quickly, and that's important information for us to know when we need to manage our patients. Safe medication administration requires knowledge of factors that alter or impair absorption of prescribed medication. Absorption is what happens to the medication from the time it enters the body until it enters circulation. The route the medication is administered directly affects the rate of absorption because each route of administration absorbs differently. The rate of absorption is related to the blood supply to the area the medication has been delivered. When the site of administration contains a rich blood supply, the medication will be absorbed quickly. For example, the respiratory tract has a quick rate of absorption due to the large amount of vascular tissue present. IV medication goes directly into the bloodstream, so those are the fastest absorbed. IM injections will be absorbed faster than sub-Q injections because muscles have more blood vessels than the fatty sub-Q layer. For orally ingested medication, the villi in the small intestine have a larger surface area than the gastric mucosa, so most ingested drugs are absorbed there, but the oral rate takes more time to absorb due to the passage of medications through the GI tract and portal circulation to the liver. We also have to look at the ability for the medications to be absorbed. Liquids are absorbed faster than tablets or capsules because solid medications have to be broken down before they can be absorbed. Coating on the surface of the medication also affects absorption. For example, enteric-coated medications cannot be broken down in the stomach and will not break down until they reach the small intestine. Another factor that affects absorption is whether or not they are lipid-soluble. Lipid-soluble meds move across cell membranes more quickly and are absorbed faster. We also need to be mindful of when the person ate because some medications interact with food. Sometimes we have to administer meds before or after meals, with meals, or on an empty stomach. And the last thing you need to be mindful of is the pH of the person. Gastric pH can affect how a medication is absorbed, and when you get to block 4, you will learn that blood pH can affect how some critical care medications work. Here are the most common routes of administration of medications. In Block 1, we'll learn how to give all of these medications except IV and medications into a body cavity. Nurses are not allowed to deliver all of these types of medications like epidural and intrathecal medication box, but nurses must know that the patient received these medications by this route and must assess the patient for any side effects. The second aspect of pharmacokinetics is distribution. This occurs after the medication has been absorbed and is now being distributed to the organs and tissues around the body by the bloodstream. The rate and extent of distribution depends on the physical and chemical properties of the medication and the physiology of the patient, meaning the vascularity of the tissues and organs and the patient's circulation. In order for a medication to be distributed to an organ, the medication has to pass through the organ's tissues and biological membranes. Some membranes serve as barriers to the passage of medications. For example, the blood-brain barrier allows lipid-soluble medications to pass into the brain and CSF. Both lipid-soluble and non-lipid-soluble agents often cross the placenta and can produce fetal abnormalities such as respiratory depression. Narcotic use in pregnancy can create withdrawal symptoms in newborns. The degree to which medication binds to serum proteins will affect medication distribution as well. Most medications bind to albumin to some extent. Protein binding can slow distribution. So here's a critical thinking question. If a patient is malnourished and has low albumin levels, how do you think this can affect drug distribution? The third factor in pharmacokinetics is metabolism or biotransformation. This occurs most often in the liver, but can occur in the lungs, kidneys, blood, and intestines. Drugs that are taken orally are usually absorbed from the small intestine directly into the portal venous system. The portal veins deliver these absorbed molecules into the liver, which immediately transforms most of the chemicals delivered to it by a series of liver enzymes. These enzymes break the drug into metabolites, some of which are active and cause the effects in the body, and some of which are deactivated and can be readily excreted from the body. As a result, a large percentage of the oral dose is destroyed at this point and never reaches the tissues. This phenomenon is known as the first pass effect. The portion of the drug that gets through the first pass effect is delivered to the circulatory system for transport throughout the body. Injected drugs and drugs absorbed from other sites other than the GI tract undergo a similar biotransformation when they pass through the liver. Because some of the active drug already had a chance to reach the tissues before going to the liver, the injected drug is often more effective at a lower dose than the oral equivalent. Thus, the recommended dose for oral drugs can be considerably higher than the recommended dose for parenteral drugs, taking that first pass effect into account. Here's a critical thinking question for you. If a patient's liver function is impaired, how could metabolism be affected? What could the implications be for us giving medications and for the patient receiving the medications? Excretion is the last phase of pharmacokinetics, and it's when the body eliminates the medication from the body. The main organ that does the excretion is the kidneys, but some medications like anesthesia can be excreted through the lungs or exhaled. Some medications can be excreted through the skin, feces, and even bile. The bile goes to the feces. It's important to know how the medications are excreted because some medications are harmful to the people not taking the medication, and if we touch the body waste that has excreted medication, we could be affected. Also, what do you think could happen with excretion if your patient has kidney failure? If the kidneys aren't able to effectively excrete the medication, what's going to happen? This is why we need to know this information. In addition to the 4 phases of pharmacokinetics, nurses need to know the key properties of medications. The first is onset. This is how long it will take for the medication to produce a response in the body. Depending on what's occurring with our patient, we may need a different route to speed up the onset. We also need to know about peak effect, which is the time it takes for the medication to reach its highest effective concentration. Think of taking medications for pain. Once you take the medication, you start to feel the pain lessen a little bit. That's your onset. But once the pain goes away, that would be the peak effect. The duration is how long the medication concentration is high enough in the body to have an effect. Serum half-life is the amount of time it takes for the drug concentration to be cut in half, meaning half of the drug has been excreted from the body. This concept is very important when it comes to timing of medications and is often what drives how often the medications can be given. The next concept we have is therapeutic range. This is the drug concentration in the blood serum that produces the desired effect without causing toxicity. If the drug level goes too high, above that therapeutic range, we call this drug toxicity. The peak level is the highest concentration of the drug in the blood plasma. The trough level is the lowest concentration level. The trough helps us understand how fast the body is excreting the medication. Peaks and troughs are drawn for certain drugs with a very narrow therapeutic index, such as vancomycin, to make sure therapeutic concentration is sufficient and to also make sure the patient isn't at toxic levels, which can harm the kidneys. The plateau or steady state of a drug is when the blood serum concentration has been reached and can be maintained after repeated doses. This is important for a lot of medications patients take to help with conditions that occur longer than, say, muscle pain after working out, those chronic medications. So why are all these concepts important? Well, let's take an example of 2 very common medications that you will learn about this semester, warfarin and heparin. Both of these drugs are considered blood thinners, preventing blood clots from forming in the body. Warfarin takes about 3 to 5 days to reach a therapeutic level, so while we're waiting for that to reach the therapeutic levels to prevent blood clots, the patient's at risk of developing blood clots. Providers will often prescribe heparin, which reaches therapeutic levels in about 20 minutes to an hour. The heparin will prevent the blood clots until the warfarin reaches a therapeutic level to prevent clotting until that warfarin level is attained. The problem is heparin has a half-life of 1 to 2 hours, so it must be given several times a day, and it's an injection, so long-term use is not an option. This is why we have to get the patient therapeutic warfarin, which is a once-a-day oral medication. Pharmacodynamics is the process of the drugs altering cell physiology and affecting the body. Drugs can turn on, turn off, promote, or block responses that are part of the body's processes, and that's how they create their effects on the body. Drugs that work on receptor sites fit with the receptor sites like a key into a lock, and this causes the effect on the body. These can be agonists, they can produce an appropriate response or antagonist, which would prevent the appropriate response from happening. Some drugs combine with other molecules in the body to create their effect. Some drugs alter cell membranes or the cell environment. For example, diuretics inhibit sodium reabsorption across the renal tubule membrane, causing the body to excrete extra sodium and the water that follows the sodium. Calcium channel blockers will block the transport of calcium across the cell membrane. Just like factors that affect drug absorption, we have factors that affect drug actions. There are many of them, and honestly, the list could go on for a while. One big factor is where the person is during their developmental stage. Children and elderly react to medications differently than adults, and pregnancy can affect drugs. A person's weight will affect how the drugs work, and some medications are dosed based on weight or body surface area. Biological sex also has an effect on how drugs work, as the different biological sexes have different muscle and water weight ratios. Most drug studies were conducted on biological males, so hormonal changes can affect these medications. This is something that is important for us to know if we are caring for a patient who is receiving gender-affirming care. Culture and genetics can also play a factor in how drugs work. There are gene mutations that will make drugs work stronger or weaker, genetics that can make some nationalities require more or less of a drug, and some cultures or religions will not take certain drugs. Some diseases, such as kidney disease or liver disease, are pathological factors that will affect drugs because these diseases can affect metabolism and excretion. Also, the timing of medications can affect drugs as well. We already discussed gastric pH and food, but also whether a drug has to be taken at bedtime or while awake matters as well. This is the end of Pharmacology Part 1.